Valley fever is one of the most commonly overlooked pulmonary infections we see in the Southwest, particularly here in Arizona. Many patients are treated repeatedly with antibiotics before they ever receive the correct diagnosis. Some are told they simply have bronchitis. Others are treated for recurrent pneumonia. Meanwhile, symptoms continue for weeks or even months before they finally arrive in pulmonary clinic. Today, we're discussing the outpatient pulmonary approach to evaluating and managing valley fever, also known as coccidioidomycosis, including key symptoms, imaging findings, diagnostic testing, and treatment considerations that providers practicing in endemic regions should recognize. Valley fever is an endemic fungal infection found primarily in Arizona, New Mexico, parts of California, Texas, and portions of northern Mexico. Here in Arizona, this is something we encounter frequently in outpatient pulmonary medicine. Yet, despite how common it is still often missed early in the disease course. One of the biggest clues should be a lower respiratory tract infection that simply is not behaving like routine bacterial pneumonia. Patients often describe persistent cough, fatigue, fevers, night sweats, shortness of breath, chest discomfort, or profound exhaustion lasting weeks despite antibiotic therapy. Some patients also develop rash, joint pain, or significant weight loss. Imaging findings can vary substantially. Some patients demonstrate focal consolidation that looks nearly identical to bacterial pneumonia. Others may develop pulmonary nodules, cavitary disease, diffuse reticulonodular changes, mediastinal lymphadenopathy, or persistent inflammatory changes that fail to resolve appropriately over time. This becomes particularly important in outpatient pulmonary medicine because many patients are referred after abnormal imaging continues to persist despite multiple treatment attempts. When evaluating these patients, exposure history matters. Dust exposure, construction work, farming, hiking, landscaping, or simply living in endemic regions can significantly increase suspicion. Importantly, many patients do not realize they were exposed at all. From a diagnostic standpoint, serologic testing is extremely important. Initial workup commonly includes coccidioids, IgM and IgG antibodies through enzyme immunoassay testing. Immunodiffusion testing and complement fixation titers can help further characterize disease activity and severity. Complement fixation titers are particularly important because rising titers may correlate with more active or disseminated disease, while improving titers can help demonstrate treatment response over time. CT imaging is frequently helpful when chest x-rays remain abnormal or symptoms persist. In pulmonary clinic, we often review imaging patterns carefully because valley fever can mimic malignancy, organizing pneumonia, chronic infection, or inflammatory lung disease depending on presentation. Not every patient requires treatment. Many mild infections in otherwise healthy individuals may improve with supportive care alone. However, treatment is often considered in patients with prolonged symptoms, substantial fatigue, hypoxemia, extensive pulmonary involvement, immunocompromised status, diabetes, or severe systemic symptoms. Fluconazole remains one of the most commonly utilized antifungal therapies in outpatient management. Patients should be counseled that improvement may take time. Fatigue and respiratory symptoms can persist for weeks or even months, even after treatment begins. Patients also need monitoring. Liver function testing is commonly followed during antifungal therapy, and repeat imaging may be necessary to ensure improvement and monitor for residual nodules or cavitary changes. One of the most important lessons in outpatient pulmonary medicine is recognizing when a respiratory infection is no longer following the expected course. In endemic regions like Arizona, valley fever should remain firmly on the differential whenever symptoms, imaging abnormalities, or persistent pulmonary complaints fail to improve as expected. If you enjoy real-world outpatient pulmonary education focused on practical clinical reasoning, imaging interpretation, pulmonary workflows, and sleep medicine topics, subscribe to the Pulmonary Perspective for future videos.